So the webinar is now being recorded. The primary purpose of this is we, Pass with Pass, decided to, we're always looking for ways to try to expand what we're doing in our ways that we're reaching students. So if you don't know, myself and Adam Petticord are the founders of Pass with Pass. We're both located in Northern Kentucky. And the primary goal originally when we created this company 5 years ago was to assist with paramedic NREMT exam prep. And we were both actively teaching in different paramedic programs at that time. And that idea is certainly kind of spiraled out of control to where we have a ton of different branches going a ton of different directions, but we're always looking for different ways to better serve you, the paramedic student, at the end of the day. So this is something that we're giving a shot, within the community in an attempt to try to build a positive atmosphere, an atmosphere where people start to know each other and get to ask questions of one another, and also see the questions that their peers ask the instructor through the forum, and then also have the ability, once every couple of weeks to jump on and do live webinars, which the topics will largely be guided by the student. So, I'm excited that I was able to offer this to you all, and that Alex passed it along to you all for a free opportunity for tonight. It is totally ironic. My understanding is you all are also covering autonomic nervous system pharmacology maybe today. I had zero knowledge of that, so it's just pure irony. But I'm glad that it worked out, and hopefully you all walk away from this tonight with a little bit more of an understanding, because it can be a pretty intimidating topic. So the luxury that we have on the back end of this is that we can take what might be 20 pages in a textbook and condense it down to 5, right? Or a 45 slide presentation and condense it down to 10, because we are truly focused on the nuts and the bolts, the lean information that we feel are the most critical to your success, not only in paramedic school, but also on the National Registry exam. So please, by all means, if you have any questions, I believe I've given all of you the ability to unmute yourself, please ask away, or you can put it in the chat. I can't guarantee to you that I'll see it in the chat right away, but I'll certainly make sure that I'm checking it periodically. So let's get started. So autonomic nervous system pharmacology. So a little bit about me. I'm currently the captain of EMS for the Hebron Fire, and right here in Northern Kentucky. I'm a co-founder and instructor of Pass with Pass LLC. We've been around for about 5 years, as I mentioned before. Previously, I've been the EMS education manager for St. Elizabeth Healthcare, EMS education manager for the Columbus, Ohio Division of Fire, director of EMS education for the Cleveland Clinic, assistant paramedic program coordinator for Gateway Community and Technical College, and an engineer medic, SWAT medic, and assistant EMS coordinator with the city of Newport. So all in all, I have about 16 years in the fire service, and 13 years in initial paramedic education. So the peripheral nervous system. The peripheral nervous system, think of it as kind of an umbrella to the sympathetic and the parasympathetic nervous systems. So the sympathetic and the parasympathetic nervous systems fall under the umbrella of the peripheral nervous system. So the peripheral nervous system itself provides almost every organ with a double set of nerve fibers. The sympathetic nervous system, which is also called the adrenergic, those fibers exit from the thoracic and the lumbar regions of the spinal cord, which is why that system is also called the thoracolumbar nervous system, or the thoracolumbar system. It's all has to do with where exactly those nerve fibers are actually exiting the spinal cord. The parasympathetic nervous system, also called the cholinergic nervous system, those fibers exit from the cranial and sacral portions of the spinal cord. So that system can also be called the craniosacral nervous system. So don't let that confuse you if you see thoracolumbar system, or if you see adrenergic or cholinergic and craniosacral. I can absolutely see those variations of terms coming up on an exam or the National Registry in an attempt to throw you off from it being a sympathetic nervous system style question or a parasympathetic nervous system style question. So neurotransmitters. So if you did learn about the autonomic nervous system pharmacology recently, this may have either really stuck with you, or you might feel kind of lost when you were talking about neurotransmitters. So what I try to do is really simplify neurotransmitters, what exactly they are, and why we actually care about them at the end of the day. So the primary neurotransmitter of the parasympathetic nervous system is acetylcholine. The primary neurotransmitter of the sympathetic nervous system is norepinephrine. And we're going to talk about these in more detail in a few minutes. So the whole reason we care about neurotransmitters is they truly deliver the signal that the nervous system is sending to the terminal, to the end destination. So we all know that the neuron is really what generates the signal. That signal travels down the axon. Remember, the axon carries signals away from the neuron. And once those signals reach the end of the axon, they come up to this thing called the synaptic cleft. So the synaptic cleft is a physical separation between the end of my axon and the beginning of my dendrite. So my neurotransmitter is what is responsible for essentially picking up that signal and driving it across the synaptic cleft to get it to the dendrite in order to land on whatever receptor sites it's ultimately going to land and affect on for it to adequately do its job. So for the parasympathetic nervous system, when the parasympathetic nervous system is sending its signal out and it's traveling down the neuron or away from the neuron through the axon and it gets to the synaptic cleft, acetylcholine is what actually drives that signal over to the dendrite so that it can ultimately latch on to whatever receptor sites, wherever those receptor sites are located, so that that effect can occur on the body. Contrarily, the sympathetic nervous system, when it sends its signal out and goes to the axon, remember axon carries the signal away from the neuron. When it gets to the synaptic cleft, it can't cross there on its own. Norepinephrine comes and drives that signal from the axon across the synaptic cleft over to the dendrite, again, so that that sympathetic nervous system stimulus can land on whatever receptor sites that it works on and cause the desired effect throughout the body. So the way that I really like to just kind of put this picture together is, don't let the word neurotransmitter or acetylcholine or norepinephrine, don't let all that intimidate you. At the end of the day, acetylcholine is the delivery truck for the parasympathetic nervous system that takes it to the receptor sites. On the other side of that equation, norepinephrine is the delivery truck that drives that signal to the receptor sites for the sympathetic nervous system. Okay, so that is why we care about neurotransmitters, and that is why neurotransmitters are incredibly important to ANS pharmacology and to the parasympathetic and sympathetic nervous system, is because without the neurotransmitters, your parasympathetic nervous system and your sympathetic nervous system, they can fire away all day long. They're never going to have their desired effect if acetylcholine and or norepinephrine don't pick them up and drive them to the other side. So hopefully that's helpful in kind of connecting the dots there. So in terms of somebody else is jumping on, so I was giving them the ability to unmute themselves if they have a question. So the parasympathetic nervous system, if we're going to look at that a little bit more closely. So again, we've already talked about, it can also be called the cholinergic or the craniosacral system. Again, because the craniosacral is where those nerve fibers exit the spinal cord, which is where it gets that name. The primary function of the parasympathetic nervous system is to maintain vegetative state and just normal body activity. So homeostasis, okay? That's the primary function of the parasympathetic nervous system. The neurotransmitter for that, we've already talked about it, is acetylcholine. The major nerve that it works off of is it's the longest nerve in your body. It's cranial nerve number 10, your vagus nerve, and the deactivating enzyme is acetylcholinesterase. So a couple things that I want to point out here. If you can remember this phrase, para aces in Vegas, and everybody wants a pair of aces in Vegas, right? If you're going to go to Vegas, you want a pair of aces. Para comes from the parasympathetic nervous system. Aces comes from acetylcholine, and Vegas comes from that major nerve that it works off of. So if you're having a hard time, and I assume you probably are, if you just learned this information recently, if you're having a hard time keeping the parasympathetic and the sympathetic systems separated from one another, and man, what was the neurotransmitter for this one, and how does this one actually function, and what effects does this one have? If you can remember para aces in Vegas, my parasympathetic nervous system is acetylcholine, that's the neurotransmitter, and it works off my vagus nerve, cranial nerve number 10. Okay, if you can remember that, you can also remember the sympathetic nervous system because it's the other neurotransmitter, right? It's norepinephrine. So hopefully that phrase is helpful in kind of connecting the dots there and remembering exactly what components of the parasympathetic nervous system exist. Any questions so far? All right. Come on. So parasympathetic drug classification. So a parasympathomimetic drug will mimic the actions of the parasympathetic nervous system. I'm sure this has been broken down before, but whenever you see mimetic, you need to automatically correlate that in your brain with mimic. So mimetic means mimic. So if it's a parasympathomimetic drug, that means it will mimic the actions of that parasympathetic nervous system. If it's a parasympatholytic, lytic means to inhibit or block, it will block the actions of the parasympathetic nervous system. So we really don't have any, there's really no great examples of a parasympathomimetic drug from the pre-hospital setting or from the EMS standpoint. So, which those aren't really going to come up in paramedic school, and they're certainly not going to come up on the National Registry exam. Parasympatholytic drugs, we do carry a very prevalent parasympatholytic medication, and we'll talk about it right here. So can anyone tell me, like I said, either unmute yourself or send it in through the chat or through the Q&A, which common pre-hospital medication is a parasympatholytic? I'll give you a little bit of time here. Anybody willing to take a stab at it? So atropine. So atropine is the most prevalent pre-hospital parasympatholytic that we are going to discuss. Okay. And I don't mean just we tonight, but I mean in paramedic school and also for the National Registry exam. Atropine itself is a parasympatholytic. So when do we give atropine? So we give atropine for symptomatic bradycardia. And even if you haven't had cardiology yet, you haven't had ACLS yet, that's fine. But I still want to explain this to you because I think it'll help kind of connect the dots on atropine and what it is and how it works. So we give atropine to patients with symptomatic bradycardia. So that means the patient is, one, symptomatic, so dizzy, lightheaded, altered mental status, hypotensive, chest pain, difficulty breathing, any of those things. That makes them symptomatic. Bradycardia, by definition, just means a heart rate less than 60. I think we all know that. So atropine is a first-line medication that we give to symptomatic bradycardic patients. So what atropine does, atropine directly does not speed up the heart, right? And that's kind of a misconception is once we give them atropine, atropine directly speeds up the heart, and that's not entirely true. So atropine is a parasympathetic. So what atropine really does is imagine we have your sympathetic nervous system on one side of the table here and your parasympathetic nervous system on the other side of the table. I know we haven't talked about the sympathetic nervous system yet, but it is a system responsible for your fight or flight. It's responsible for tachycardia. It's responsible for getting your blood pressure up, right? It's responsible for those fight or flight actions that you would have. Whereas your parasympathetic nervous system, as we have already discussed, is just for vegetative state, right? When I go to bed, my parasympathetic nervous system is the primary nervous system that is having that effect on my body. So let's say right now, I am 50-50. My sympathetic nervous system is responsible for 50% of what I'm doing right now. My parasympathetic nervous system is responsible for the other 50%, meaning that I'm not getting ready to explode and jump through the walls, but I'm also not falling asleep as I'm sitting here talking to you, right? So I have good homeostasis going here. My nervous systems are balancing one another out. So let's say I'm at 50-50, but my heart rate at this 50-50 combination is 44 beats per minute, right? No bueno. That's not good. And on top of that, I have an altered level of consciousness. I have a decreased blood pressure. So I'm a little hypotensive. So now I'm symptomatic and I'm bradycardic. So this is when we give atropine, right? So atropine is a what? It is a parasympathetic, meaning it blocks the parasympathetic nervous system from doing its job. My parasympathetic nervous system is responsible for my vegetative state, for me falling asleep, right? For everything kind of shutting down. My heart rate drops, my blood pressure lowers. So when I give atropine to this patient, it's not making my heart rate go up directly, but what it is doing is it's inhibiting my parasympathetic nervous system from functioning really at any capacity, but not much of a capacity at all. So now just hypothetically, let's say that my sympathetic nervous system is now running at 90% capacity and my parasympathetic nervous system is running at 10% capacity. So now that my sympathetic nervous system is the primary nervous system that's operating right now, my heart rate's going to go up. I'm going to have vasoconstriction, so my blood pressure is going to go up. I'm going to have pupillary dilation. All of these things are going to happen because we gave the atropine for this low heart rate. Okay, so the way that I like to explain it is atropine is essentially playing defense on the parasympathetic nervous system so that my sympathetic nervous system can run unopposed. My sympathetic nervous system is no longer meeting resistance, so the door's wide open for it to take over my body and to increase all the bodily functions that are normally stimulated by the sympathetic nervous system. Okay, so the big takeaways there. Atropine is the most common parasympathetic medication that we are going to give or talk about in the pre-hospital setting. We're going to give it to those symptomatic bradycardic patients, and not because atropine directly speeds up the heart rate, but because it prevents our parasympathetic nervous system from really doing its job, which would maintain or put a lid on the heart rate, so to speak. So hopefully that made sense to you all. All right, so let's talk about the sympathetic nervous system. The sympathetic nervous system is also called the adrenergic or the thoracolumbar, again, because the nerve fibers exit from the thoracic and the lumbar portions of the spine. The primary function of the sympathetic nervous system is fight or flight. right? So this is, I'm getting ready to beat somebody up, or I'm getting ready to get beat up myself, right? I don't know which one's going to happen, but something's about to happen. So all of my body systems increase. So my heart rate goes up, my blood pressure goes up, my pupils become dilated. All of those things happen when my sympathetic nervous system is what's really stimulated. The primary neurotransmitter of the sympathetic nervous system we already talked about is norepinephrine. The deactivating enzymes, we really don't have to worry about these too much. The monoamine oxidase and the catecholomethyltransferase. The only thing you may see from these two is you may see a classification of medications called MAOIs, and that's monoamine oxidase inhibitors. Okay, so if you see that type of medication, don't freak out. It's an inhibitor. So it inhibits monoamine oxidase. If monoamine oxidase is responsible for part of my sympathetic nervous system being able to function and do its job, then an inhibitor of monoamine oxidase must mean that it's trying to inhibit, ultimately, my sympathetic nervous system from doing its job. So maybe in a means of heart rate control or blood pressure control. So sympathetic drug classification, sympathomimetic drugs. Again, when you see mimetic, you think mimic. Mimic the actions of the sympathetic nervous system. Sympatholytic drugs, when you see lytic, you think block the actions of the sympathetic nervous system. So what drug, and please feel free to send it through in the chat or unmute yourself. What drug do we give is a sympathomimetic? What drug do we give that mimics the actions of the sympathetic nervous system? Give me something. All right, I got somebody here. Epi. So thank you, Andrew. I appreciate that. So epi, 100% correct. So sympathomimetic medication is epi, right? And primarily we're talking about epi 1 to 10,000 or 1 to 10 when we talk about a sympathomimetic drug. So epinephrine absolutely mimics the actions of the sympathetic nervous system. So when we talk about the sympathetic nervous system, there are two types of receptors. There's alpha adrenergic receptors, which are alpha 1 and alpha 2, and there are beta adrenergic receptors, beta 1 and beta 2. And you guys are going to get a lot of test questions on alpha 1, beta 1, and beta 2. Okay, I'm telling you right now, don't say I didn't tell you so. And I don't mean just from the National Registry, but you're also going to see it in paramedic school. I can almost guarantee you are going to get test questions about alpha stimulation, beta 1 stimulation, and beta 2 stimulation. So let's talk about alpha 1 receptors. So alpha 1 receptors are found in smooth muscle. So when these alpha receptors are stimulated, because they're in smooth muscle, they cause vasoconstriction, they cause pupillary dilation, and decrease renin secretion. And if you think about your sympathetic nervous system has to be stimulated in order for my alpha 1 receptors to be stimulated, it makes sense as to why these three things occur, right? So if I'm in a fight or flight situation, my heart rate's going to go up. I'm going to have vasoconstrictions causing my blood pressure to go up. My pupils are going to become dilated. Why? Because when your pupils are dilated, you have better peripheral vision, right? You can see more what's going on, and decrease renin secretion. Because quite frankly, nobody wants to be in a fight or flight situation and have to pee, right? So decreased renin secretion is also going to help to keeping blood pressure up, of course. So alpha 2 receptors, we don't really talk about alpha 2 receptors too much in the EMS setting, but they're actually pretty interesting. We won't dive deep into them here, but they actually have sympatholytic effects, right? Which is kind of hard to wrap your head around. But alpha-2 receptors, which are receptors of the sympathetic nervous system, they actually cause, when stimulated, they cause an inhibitory effect, that lytic, on the sympathetic nervous system. So if my sympathetic nervous system is being blocked by alpha-2 receptor stimulation, what are some things you think we could see? Now, I'll give you a hint. It's almost the opposite of what we can see with alpha-1 receptor stimulation. So we're going to see vasodilation, decreased, which is going to cause decreased blood return back to the heart, and we're going to see bradycardia. So alpha-2 receptor stimulation actually has an inhibitory effect on the sympathetic nervous system, and it causes vasodilation, it causes decreased blood return back to the heart, and it causes bradycardia. Now, I don't know if you've been in cardiology yet. If you have, and you know the answer to this question, please tell me. So if I have decreased blood return back to the heart, and I have bradycardia, so decreased heart rate, what is that ultimately going to affect? What is that formula that I'm referring to there? Decreased cardiac output, 100%. Excellent job. So this is going to ultimately cause decreased cardiac output. Remember that formula for cardiac output is stroke volume times heart rate. That equals cardiac output. So stroke volume is the amount of blood and volume, so in milliliters, that is ejected with one contraction. And generally, it's around 70 milliliters of blood. Heart rate, we all know what heart rate is. So when I multiply my heart rate by my stroke volume, which we don't have a way to assess in the field, that tells me what my cardiac output is. My cardiac output is how much blood is being circulated in 1 minute of time. Okay. And you guys will learn a lot more about cardiac output once you get into trauma, if you haven't been there already. But alpha-2 receptor stimulation, I don't think you're getting any test questions on it in paramedic school. I really don't think you're getting any test questions on it on the National Registry exam, but it is pretty interesting to know that it actually has sympatholytic effects when it's stimulated, which can actually work against the whole sympathetic nervous system to begin with. So let's talk about dopamine for a second. So dopamine is going to be a medication that if you don't already dislike it, you're probably going to, because it's a weight-based drug formula calculation. I'm happy to go over that with you all if you're there, and if it's applicable timing. If it's not, don't start beating your head against the wall. If you haven't learned about dopamine yet, let it be taught to you naturally in the paramedic program. But dopamine is a pretty interesting medication because its effects are based on what dose you're administering. So if you give 2 to 5 mics per kilogram per minute of dopamine, you're going to have dopaminergic effects. And that actually causes some renal and mesenteric dilation, vasodilation. Okay. And we're not going to be giving doses at 2 to 5 micrograms per kilogram per minute. The doses that we are going to be more focused on in the EMS setting are these 3. Okay, so our 5 to 10, my 10 to 15, and my 15 plus. So 5 to 10 micrograms per kilogram per minute, those are going to give me a combination of both beta and alpha effects. So I have beta bolded there because you're going to see more beta effects than you will alpha effects at that dose range. Now, as you get closer to 10 mics, and as you eventually surpass that 10 mic mark, and you get from 10 to 15 mics per kilo per minute, now you're getting alpha and beta effects, but your alpha effects are what's being seen more so than your beta effects with those dosages. And then once you get to 15, 20, even higher doses of dopamine, which most protocols don't call for. Most protocols, if they do include dopamine anymore, which a lot of them don't, but if they do, it's somewhere here around this 5 to 10 or 10 to 15 mark. But once you get to 15 and 20 and higher of mics per kilogram per minute of dopamine, you're looking at pure alpha effects there. Okay, so just pure vasoconstriction. So now let's talk about beta 1 receptors and beta 2 receptors. So the easiest way to remember this, or at least for me, and I think for a lot of paramedic students that I've taught over the years, beta 1 receptors, you have one heart. So beta 1 has an effect on your one heart, okay? And when beta 1 receptors are stimulated, it causes three things to occur, all right? So you have inotropy, chronotropy, and dromotropy. So inotropy is the strength of cardiac contraction. And I'm writing on a laptop with a stylus, so bear with me, okay? Even though my handwriting is not much better than that anyway. So inotropy is the strength of cardiac contraction. So how hard is my heart actually squeezing? When my beta 1 receptors are stimulated, it increases the strength of which my heart is actually contracting. So a way that I kind of remember that is inotropy, I think iron. And I know iron is really strong, right? So I've always been able to correlate that in my brain with inotropy means strength of contraction. Inotropy, think iron. Iron is strong, okay? Chronotropy is the rate, okay, or heart rate. So how fast is your heart actually beating? So when beta 1 receptors are stimulated, I have positive chronotropic effects. Chronotropy refers to rate or heart rate. How do I remember that? Conveniently, I have an HR right there, right? So that HR and chronotropy helps me tie together heart rate. Some other people that I've heard have said chronological, right? Chronotropy, chronological. Chronological refers to time, and your heart rate, how many times a minute is your heart beating. I can kind of see the correlation there. But for me, that HR and chronotropy has always just been able to again, correlate in my mind with that refers to heart rate. When I have beta 1 stimulation, I have positive chronotropy. It's going to increase the rate at which my heart is beating. And then dromotropy is the speed of electrical conduction or automaticity. Okay, so dromotropy refers to the speed of electrical conduction. How fast is your SA and AV node and bundle of His and Purkinje fibers? How fast is that actual process happening, right? And if I have a positive dromotropic response, it means that my SA node and AV node, that entire electrical conduction process is going to be happening even faster, okay? Any questions on beta 1? Remember, beta 1 means you have one heart. My one heart, when it's stimulated, it can have three effects. Inotropy is strength of contraction. When you think inotropy, think iron. Chronotropy, that HR and chronotropy is there for a reason. Think heart rate. That's how fast my heart's beating. Dromotropy is the speed of electrical conduction and automaticity of the heart. Any questions on that? All right. So now let's talk about beta 2 receptors. So with beta 2 receptors, I have two lungs. So my beta 2 receptors are going to work on my two lungs. When we get beta 2 stimulation, we get bronchodilation. Okay, so it's not that my lungs really open up anymore, but my bronchi and bronchioles, more specifically, actually open up and allow for more air passage down into my alveoli. So what is a selective beta 2 agonist medication? And this is an EMT medication. So it's obviously a paramedic medication, but what medication do we give pretty frequently as a selective beta 2 agonist? Let's see here. Albuterol, 100% correct. So albuterol is a beta 2 agonist. We give albuterol for patients with difficulty breathing, patients who are wheezing, patients who we feel would benefit from bronchodilation to help open up the bronchi, open up the bronchioles to allow air to get down into the lungs more freely and into the alveoli for that gas exchange to take place. So albuterol, that is my selective beta 2 agonist. Okay. Non-selective beta agonists, we really don't have any pertinent examples of that in EMS, but what I would say ultimately, epinephrine could fall into that category because epinephrine does, it obviously works on your one heart. It increases the strength of contraction. It increases the heart rate. It increases the speed of electrical conduction. And we do know epinephrine does have some bronchodilatory effects as well. So non-selective means it doesn't only work on beta 1 and it only works on beta 2. It's non-selective means it works on beta all across the board. So epi could be an example of that, of being a non-selective beta agonist. All right. So this is, I think, one of my last slides of content, and then I'll open it up for you all if you guys have any lingering questions about this or any other topic, quite frankly. So beta blockers. So this is pretty important to kind of comprehend. So there are two types of beta blockers. There are selective beta blockers, which I just told you means they only affect either beta 1 or they only affect beta 2. That's selective. And there are non-selective beta blockers. Okay. So some of these selective beta blockers are they're only for beta 1, so they're cardioselective. Metoprolol and atenolol. Those are both beta blockers because they end in LOL, but they are specific to beta 1. They don't block any of my beta 2 receptor sites, which is excellent, right? And we'll talk about why. Non-selective beta blockers. So this is, they don't care what you are. They don't care if you're beta 1. They don't care if you're beta 2. If you're beta, they're blocking you. Nadolol, propranolol, and labetalol. Again, all beta blockers because they end in LOL, but they are non-selective. So they are going to block beta 1, which is really the primary intent for blood pressure control, but they're also going to block beta 2. So if I have a patient, let me ask you guys, what type of patient would I be concerned about being prescribed a non-selective beta blocker? What type of patient or what type of patient history would I be concerned about being prescribed a non-selective beta blocking agent? COPD, 100% correct. So any patient who has any type of breathing problem, right? My COPDers, my asthmatics, obviously emphysema and chronic bronchitis fall under that COPD tree. But anyone who has any type of breathing problem, we don't want them to be prescribed a non-selective beta blocking agent. Why? Because if they are, their beta 2 receptor sites are blocked because of the labetalol or the propranolol or the nadolol. And all of a sudden, my albuterol treatment isn't very effective in the back of the medic unit when their SATs are 88%, right? When they're having a COPD exacerbation or when they're having an asthma attack. So hopefully, and this is where we really trust physicians to look at patient history before they prescribe a medication. Hopefully, if the patient has COPD or asthma or some type of significant respiratory illness, and they need a beta blocker as an antihypertensive, they are getting metoprolol or atenolol. That way they can take that, they can have those beta 1 blocking effects like we want them to for blood pressure control. But if they have that COPD exacerbation or that asthma attack and I need to give them a breathing treatment, I need to give them that albuterol, I still can because my beta 2 isn't affected by that. Okay. So that's something that's pretty important to keep in mind. I don't necessarily know if you'll get any test questions on it, But I do think it's really important to connect those dots for the field and for the clinical setting. And you guys are, a lot of you are released for clinical time and in the field. A lot of you are seeing these patients, and hopefully you're able to identify them. So a question was asked, what's the benefit of non-selective over selective? So it really just depends. That's a great question. So it really just depends on the patient. It depends on what type of other history they have. Some medication, some of these beta blockers work better in different demographics, like labetalol. Labetalol is a fantastic medication. It works really, really well. I would say labetalol probably works better than nadolol. It probably works better than propranolol. It's just a really good medication, and there's a lot of EMS agencies that carry it, although not necessarily in this area. Whereas metoprolol and atenolol are beta-1 selective, and those are probably only going to be prescribed if there's a concern for some type of respiratory illness down the road. Some patients are going to some patients are naturally going to respond better to different medications, right? A good friend of mine was taking labetalol. He felt absolutely terrible with it. He had zero energy, felt like crap. He looked like crap. He switched over to metoprolol and felt like $1 million. So I think it's really probably just more so trial and error, looking at patient history, seeing can they have a non-selective beta blocker? Do they really need a selective beta blocker because of some other type of medical problem? But I think ultimately it's part trial and error. And we all know some physicians are just more keen to certain medications than others because they've been prescribing it for years, right? So I don't necessarily know if there's a tremendous benefit to using non-selective beta blockers, say, all the time, right? If our patients don't have a respiratory illness, more so than just which beta blocker and which medication works better for the patient. And a lot of times with beta blockers, the drug itself and the dosing takes a lot of work to hone in to figure out exactly which medication and which dose works best for you, that it doesn't really screw things up. Good question. All right. So that's what I have from a presentation standpoint. I am happy to answer any questions you have about this content, about anything else, about when we're going to do this again. The floor is your all's, truly. We spent 45 minutes exactly talking about ANS Pharm. Hopefully it was a good review. Hopefully it was a helpful review, and hopefully it helped connect some dots that can linger from paramedic class and from the textbook, certainly. So hopefully it was helpful. Please, by all means, feel free to unmute yourself or throw a question or send a message through the chat, and I'm happy to answer any questions you have. Well, and I'm open to feedback as well. You're welcome. Thank you. Are there any other drugs other than dopamine and epi that are alpha selective that we use? So, locally, here in Northern Kentucky, I'll say, no. Dopamine and now push dose epi is really replaced dopamine and all the protocols, are really going to be the alpha, and I'll say alpha selective. The epi is not necessarily alpha selective. We can give alpha selective dosing with dopamine, but we can't really give alpha selective dosing with epi. So we're giving epi primarily for those alpha effects, right? Because we're generally, when we're given epi from this type of situation, we're giving it because there's low blood pressure. We feel like the blood volume's there. We don't think it's like a hypovolemic or a hemorrhagic shock. So it's not a fluid problem, but it's more of I need to squeeze my vessels and shrink down my vessel problem, right? So I need vasoconstriction. So epi is going to provide alpha effects, certainly, but it's also going to cause some beta-1 and beta-2 effects as well. So it's not necessarily alpha selective. It's just a sympathomimetic. It mimics the sympathetic nervous system. Dopamine, on the other hand, can absolutely be alpha selective. It all just depends on what dose we use. But some agencies, again, not necessarily in Northern Kentucky or Greater Cincinnati, but norepinephrine is another vasopressor that is commonly used in EMS, just not necessarily in the area that we're familiar with. But so norepinephrine would be added to that list. I think there's a chance that we could see it in Northern Kentucky, in the Greater Cincinnati area over the next few years. Don't read too much into that, but because it is being proven to be a very great medication, a very safe medication, oftentimes safer than dopamine and more effective than dopamine. But there's really no other medications that are alpha selective that we're using currently. So which direction do impulses travel in the neuron? So I'll jump back to that slide so that we can take a look here. Erase this mess I have on the screen. So remember, from the neuron is what is ultimately sending the signal. It's traveling to the axon. This is the axon. The axon carries a signal away from axon A, is away from the neuron down to the synaptic cleft. And that is where these vesicles, is how it's labeled on here, but these vesicles that are carrying the beta 1 receptor stimulants, right, or beta 2 receptor stimulants, they come to the end of the axon. They get to this synaptic cleft, which again is a physical separation between the two structures, and then that appropriate neurotransmitter has to pick up the load there at the end and take it across the synaptic cleft and get it to the other side, to the other set of nerve fibers, for it to be able to continue on and go to the heart and go to the lungs and go to these different places to actually have the appropriate effect. Hopefully that answered your question. Oops. So while you're welcome. So while I'll hang out for another few minutes and see if any more questions come in. I appreciate you guys asking them, and I appreciate you jumping on. I'll do a shameless plug here. Again, I told you all who are joining us free this evening. I gave you a code for one month free in the community. I encourage you to jump around in there and take a look at it. And again, it's something new that we're trying in order to best reach our students of where they're at. You can always cancel at any time, but the ultimate goal is for that to be a place where students can communicate with one another. They can communicate with me. So you can ask a question in there. I will answer your question generally the same day, generally within a few hours. And you're able to see the questions that your peers asked and what answer I gave. And then the goal is to ultimately do some type of webinar, live webinar review, like every other week. And that would largely be guided based on the feedback that you all were given in terms of what lectures you'd like to see or where you're at in paramedic program. So we do have study guides. We do have an online and on-demand paramedic review course. And you guys will hear more about that, but you're welcome. Thank you very much. But yeah, so that's who we are, and that's kind of the goal of this. And if you guys, like I said, you have a month, so you guys will definitely get one more webinar opportunity out of this if you don't choose to continue on with us. So if you have any other suggestions or topics you'd like to review in this type of format, let me know. I think all of you got the email address, team@passwithpass.com. Send us an email, and I'll be happy to put something together based on the majority of your all's feedback. So again, I appreciate it. I'll hang on for a few minutes and see if there's any more questions. And then other than that, if you don't have anything, again, thank you for jumping on. I appreciate it, and have a good night and good luck in paramedic school. And hopefully we see you in another week or two on here.